So we do your pupil examination now, and what I want you to do is focus on a distant target and just keep your eye right on that spot. And first, with the pupil examination, we want to illuminate the pupils generally from below with an even light source, and pay just observation, just sort of careful attention. Are the pupils the same size? Is there physiologic instability, hippus? In her case, there's actually a slight anisocoria, in that the left pupil is just a little bit larger than the right. So we're just kind of in a general sense, but both pupils are round. And then we're going to examine each pupil individually. We're going to look at the two phases of pupillary constriction and escape. So the initial constriction, and then there's a little bit of escape. And we'll do that each eye one at a time. You can blink though. It's okay. Okay. So just focus straight ahead there, and then we illuminate each eye. Open your eyes wide for me for a second. Good. And then we're looking at the initial constriction of the pupil. And that eye is not constricting very well. So this is actually an interesting example of something called an efferent pupillary defect. Look straight ahead. We're going to check to see if there's an efferent. So an afferent pupillary defect, this is the medical terminology and jargon. I'll explain this in English in a minute. So an afferent pupillary defect is a deficit in the optic nerve. Afferents going in, efferent is the motor effector nerves that go to the pupil to cause constriction. So those are two pathways involved, and that's sort of the yin and yang of pupillary constriction. Light sensation is the afferent, and then the efferent is then the motor response to the light sensation. So in this case, we would expect both pupils individually to show equal constriction. So if we look at this one a few times, constricts, a little bit of escape there. Open your eye wide again for me, just like that. Good. Constrict, and then a little bit of escape. And on this side, we go constrict, a little bit of escape, constrict, but not the same briskness of pupillary constriction. So the efferent phase is what I'm suspecting. The way we tell that, actually, is we look at what happens to a pupil when we do the other side. So now illuminating her pupil from the side here, so she's not really getting too much light in the right eye, and we're actually looking at the eye that I'm illuminating while I shine. Look at the constriction there. Okay, so you have a pretty good constriction. Now we're going to compare that to the other side. So illuminating from the side. And then what we want to know, is this an efferent or an afferent defect, is if the pupil constriction is the same in that eye versus that eye. So now we're doing a swinging flashlight test, and she has a small afferent pupillary defect in the left eye. So when I swing from the right eye to the left eye, there's dilation, not constriction. Blink a couple times, and I'm going to ask you to open your eyes wide and try not to blink just while I swing back and forth a few times, and I'm going to put your chin down just a little. You like your head back a little bit too. Open wide, and then we'll just do a swing a few times and just watch the pupil dilation. When I go to the left eye, it gets bigger. Right eye constricts, left eye gets bigger. So this looks like primarily an afferent defect, although I'm still seeing not quite the same constriction in the left eye. So there may be some damage, and again, in neuromyelitis optica, NMO, there's a lot of brainstem involvement, and we can see efferent defects more commonly actually in NMO. We see it in MS to a lesser degree, but again, the diseases are fairly similar, and they attack similar areas of the brain, especially when it comes to control of eye movements.
Yes, sir.
So the other issue relates to the optic nerve itself. We get the red reflex. So we have some temporal pallor in this eye. And then examination of the other
I've
eye.
not had that before. Does that mean optic neuritis is starting in that eye again?
No. That's
Okay.
an old finding.
Okay.
That once the optic nerve has been damaged, it'll always look like that. And then really diffuse pallor in this eye. Has Dr. Hunter explained
He has.
this too? I'll probably go over
Yeah.
it again in a similar way.
He explained to me that like 50% of this nerve was gone, and
Yeah.
this other. Madison, can you listen to all this? And that my brain would learn to compensate the difference in the eyes, and I had a little bit of a hard time accepting that, but I've learned to deal with it.
Yeah. This
Which
is
I've had no telling how many of those done, not just here, but I've saw eye doctors from Vanderbilt and ophthalmologist, neurologist in Louisville, and so I was in denial for a little bit about it. So, but when everybody keeps telling you the same thing, then
eventually you have to
yep,
shake you out of your denial.
yes, sir.
Denial ain't just a river in Egypt.
Well, and I was just kind of trying to, I guess, look for maybe somebody who knew something to do. That this was before I started seeing Dr. Hunter, so I saw Dr. Kim at Vanderbilt and Tennessee Retina. I've seen them also. So I've had like the vegetable oil run behind my eyes and all of it.
You had the what?
Is it like vegetable or chicken grease or something that? Yeah, it was like all over my arm when they did it, but
What?
it highlights the back of the eyes or something. I don't know.
They give you an injection?
The IV, yep.
Yeah, no, that injection of dye they give you will fill up the blood vessels in the back of the eye, and then they do some red-free pictures so you can see if the dye is leaking into the retina, out of the blood vessels into the tissue. So that's
Yes, sir.
something called a fluorescein angiogram.
I've had that also.
So, yeah. That's more for retinal disease, although we can see with NMO some of...
That was prior diagnosis of NMO.
So you've been diagnosed with neuromyelitis optica.
Yes, sir.
And that's a distinct disease from MS. They're similar in some ways in the way they damage the nervous system, but different in others. I'm curious as to how your how this evolved, kind of when your symptoms, your visual symptoms, was that the first problem you noticed was a problem
Yes,
with your
sir.
vision?
Optic neuritis in 2012.
That was the first time you'd ever had any neurological problems?
Yes, sir. I went completely blind in my left eye.
That was a left eye?
Yes, sir.
And how quickly did that happen? Was that something that
It
came
happened
on
like I was up that morning. We were going on a family trip that day. It was very hot outside. By that afternoon, I could not see. I had a massive headache.
So, and you had pain?
Yes, sir.
Was it
Behind my
worse
eye.
when you would move your eye
Yes,
from
sir.
side to side, up and down?
Yes, sir.
Okay, so it came on rather quickly. Over the course of a day, you went from noticing something not quite normal to not being able to see at all?
That's correct.
Out of the, I'm sorry, which eye did you say? The left?
my left eye. Yes, sir.
So, when you say you couldn't see at all, you couldn't see shapes or forms? How about light? Could you see
I could
light?
see light, and it seems like
could you
there's
see
like a
your
little.
hands in front of your face?
It seems like there's like a dark circle.
Oh.
No, because
No.
when I went, like I didn't go to the emergency room that day or anything because I'd worked in healthcare for years, and finally takes the doctor I worked for at that time, and we were kind of thinking maybe I'd had a stroke because I'd been in the heat, and so I went to my family doctor the next morning, or my family eye doctor, and she said behind my eye was just cobwebs. That was all she could see. So I was in an MRI tunnel by that afternoon. So
Did she see problems? You recall when she said cobwebs, did you see that in your retina inside your eye, or was she talking about your optic nerve?
my optic nerve.
Optic nerve, was
Yes,
that
sir.
normal? Okay. So what happened after that? You said fairly quickly you lost a lot of vision.
I did.
And you said there were areas that you couldn't see, like
There
blind
were
spots?
areas that I couldn't see. So I had an MRI that Monday.
But before we get there, in relationship to your vision, when you would, if you were looking straight ahead out of your left eye, was it right in the middle that you couldn't see?
Yes, sir,
or
it was
more
the
off
middle.
The side?
No, it was the
so
middle.
What we would
Yeah.
call a classic central scotoma.
Yes, sir.
So in the peripheral vision, were you able to see things pretty well?
The best I remember, yes, but it was that central vision. I mean, it was gone.
Right. But you could see movement and shapes
Yes,
in your
sir.
side vision in that eye? Okay. And then how did that change over time?
I was started on high-dose IV steroids that week.
Right.
And then
So
I
then
was,
I interrupted your story, but you said you did get an MRI scan,
Yes, sir.
and the MRI was abnormal?
yes, sir.
At the time, okay.
So, seeing neurologist that Thursday. By working in healthcare, I was kind of pushed through quickly.
Good, yeah. You're one of ours. We take care of our
And
own.
it was probably a few months. Like, I gained vision back within a month, but it's never been what it was
So
before.
from where you started at 100% full vision in that eye, how much do you think you recovered? 50%?
Maybe
Maybe. What do you think?
50%. Maybe.
So maybe not as good as 50%, maybe less than that?
There's days that it still acts up and it might be 40, 30.
Well, then 2 to 3 months after that event, you'd say
It was about 50.
You're about 50% loss of vision at that
Yes,
time
sir.
from that single event.
Yes, sir.
Okay, and you never had any other problems with that eye, vision loss-wise?
Yes. After that, I've
Before
had...
that?
Before that, no,
Yeah,
sir.
okay. All right.
No, sir.
So first event, single event, you lost greater than 50% of your
Yes,
vision.
sir.
It didn't recover even over a 3 to 6 month period of time.
Yes, sir.
They gave you some steroids.
Yes, sir.
Okay. At that time, were those the only symptoms you were having?
Yes, sir, at that time.
Okay.
That was all, like if I think back, I'd had some other things that kind of stand out. But at that time, that was it, was the optic neuritis.
If you're like most people with NMO who present with a optic neuritis just in one eye, you were probably diagnosed with MS?
Yes, sir.
Did you have a spinal tap done?
No, sir.
Okay.
Refused. Yeah, this is my decision, so.
Can't say I blame you on that. I'd have to think about that long and hard myself. So, first event, lost a lot of vision. What about the pain?
It was unbearable. Like
How
the
long-
very first day that it happened, the little rolls of Tylenol they sold at the convenience stop because we were trying to get home because, I was feeling so bad. I took the whole thing before I got back home. No relief.
Did the pain improve once you got the steroids?
Yes, sir.
Okay. And so that went away over
I
what,
still
a week or two?
have
You still
pain
have it
in behind
sometimes?
behind that eye, but it decreased with the steroids.
Good. Okay. There were other things that happened to you that I know about. I think you'll have a couple other doctors interview you too.
Yes, sir.
I'll kind of let them get into more of the other neurological symptoms. You down the road had a major spinal cord event.
I did.
Dr. Hunter was telling me too, and
Yeah.
so sometimes it's pretty hard to diagnose NMO from the first event, but probably one of the biggest clues is incomplete recovery from optic neuritis. Now, unfortunately, my experience in people with optic neuritis who have MS is it's not that unusual to see a fairly large deficit following the first event of optic neuritis, but it's much more common to have incomplete recovery after NMO. I say not unusual for MS to do that. It would be a little unexpected. The first attack of optic neuritis in somebody with MS, usually the recovery is pretty good. In fact, one of the red flags that we look for as clinicians, neurologists, is if someone has either a major spinal cord deficit or in this case a major optic nerve deficit and they don't recover very well. If someone, typically I'll see this in someone who's had MS for a while where they've had a few attacks of optic neuritis in the same eye. If you have repeated attacks, and that's kind of why I was asking you about that.
Yes,
you
sir.
lost vision with the very first event. If you'd had repeated attacks in that left eye, and then you had another one and didn't recover very well, that would be a little more typical of what we see for people with MS in terms of their visual recovery after an attack, after a single attack of optic neuritis. Multiple attacks of optic neuritis, yeah, we don't see quite as good visual recovery. We've got a few things here, and you said you've had more of these done.
Oh
We
yeah,
have
I've
a
had
couple-
several, sir.
We have a couple of measurements through the back of your eye. Now this is something called optical coherence tomography. We'll just call it OCT from now on because
Okay.
that's a mouthful.
Okay.
Like we don't say neuromyelitis optica.
Right.
We just call it NMO because we're tired of spitting that out every time. So this first, and these are two different years, or actually the same year, a month apart. So I think we'll just show they're fairly similar. This one actually looks like it's a little bit better study. So so this is a measurement of kind of two areas in the back of your eye that are really, really important for MS or NMO. the optic nerve, and the macula. So this is a scan of your macula, and I know this has probably been explained to you, but I'll just sort of step through what we're doing here. So in the very center, this little blue dot is this little pit. That little pit in the back of your eye is where your absolute most important vision, as far as acuity, detail, distance vision, reading road signs when you're driving, reading details, color vision, and something we call contrast sensitivity. Contrast is the ability to distinguish subtle shades of gray. People tend to have contrast problems, or rather what you would notice as a contrast problem would be when it's gray, dusk, overcast conditions, very, very difficult for you to see, although you may be able to see black on white pretty well, but shades of gray, really tough. In Minnesota, where I live, during the wintertime, you don't get too much of that here, but when you get a lot of snow and a flat, gray, overcast day, very, very difficult to see those subtle differences. And the better light, the more contrast you have between black and white, the easier it is for you to see. So many people recover their visual acuity. By that I mean the black, when you go to the eye doctor, you read the eye chart with the black letters on the white background. Many people after optic neuritis recover pretty well their visual acuity, but they keep this kind of residual difficulty with distinguishing these subtle shades of gray. If we have time later, I think I want to actually check your contrast vision.
Okay.
And have a little eye chart that I'm along with me. We'll kind of see what your contrast is like.
Okay.
You're going to hate it. It's a hard test. It's just hard for you to see the gray letters.
Okay.
Now, this is actually a direct measurement of the layers in the back of your eye. So the layers of your retina, and this little dimple is the macula, and the one in your right eye is actually pretty normal. There are actually some measurements within this little grid here, and these are compared to age-matched normals. This one's maybe a little thicker than it should be, but within it's fine for what it is. What we see though is a stark difference between the thickness of the nerve cells in the retina in your left eye, and that you have 263. These are measured in microns. I sometimes do speaking engagements for other patients, and when we talk about microns, and invariably there's an engineer in the audience, and I ask, is there any engineers here? And someone will raise their hand, and I say, what's a micron? And they go, very little. You know, engineer is really precise, but they go little tiny. Micron is very, very small. We're measuring subtle layers in the back of your eye, and this very top layer here is a layer of nerve cells.
Okay.
So this map is measuring the deeper down layers of the retina just around this dimple. And you can really see a stark difference, and that means a lot of these nerve cells died. Okay. Whether that was with the first event or not, other events along the way will gradually pick away at the optic nerve. Now we did another measurement here, and this is measuring. That's your optic nerve in the center, and the little ring around it is we're measuring the nerve cells right around your optic nerve rather than in the center of your retina called the fovea or the macula. Now, you don't notice too much problems right around the optic nerve. Maybe everybody has a normal blind spot that's about 15 degrees in the temporal visual field on both eyes. And that's where your optic nerve is. But this is measuring the thickness of those nerve cells, and in this little image, it's kind of showing you where the nerves are not. Here's showing you where they are, and you can see the difference. Then the average thickness of 92 microns in your right eye is pretty normal. When I looked at your optic nerve on your examination in your right eye, there is a little bit of paleness in the optic nerve, in the temporal portion of the optic nerve, which is pretty much where we tend to see MS, NMO to a lesser degree does it too, but will affect that part of the optic nerve. But otherwise, your right eye looks pretty healthy, doesn't look like there's a lot of damage, and this average thickness of 92 microns is actually pretty normal. It's pretty much in the normal range. In your other eye, however, you see 63 microns. Now, what we can kind of use these numbers to get a general sense of when somebody's likely to have vision problems. And if you have 92 microns, no worries.
Okay.
Even if your right eye got down like around 80, 85, low 80s, high 70s, maybe more problems with contrast vision, but usually people aren't having big issues with their vision. Now, your right eye is really important to you given the amount of damage in your left one. So
Yes,
it's
sir.
really preserving the vision in the right eye is really key for us right now.
Okay.
So the damage that you have in the left eye, unfortunately, is a done deal. We can't grow back those
Right.
nerve cells. And even more important, as I said, for the right eye. So we want to make sure, and this is an important thing to track, but it also demonstrates the difference. In someone who has optic neuritis, they would tend to lose approximately 20% of the nerve cell thickness after an event of optic neuritis. Don't know what your measurements were 6 months or so after the first event, but I suspect they were close to this. And this amount of difference, by the time someone gets down into the 60s and 50s, 40s, is when we really get really severe, profound vision loss. So prevention is the name of the game, and there are treatments. We'll talk more about that in another session. But
Okay.
For the time being, this would be an important assessment to have done regularly and to monitor regularly. And I would encourage you to kind of stay plugged in and have this done on a regular basis. I want to take a minute and look at you. Dr. Hunter said you had some interesting eye movement problems. And
I did, sir.
I'm going to just take a quick look at that now.
Okay. All right. Absolutely fine.
So now just follow my finger with your eyes.
Okay.
And actually I'm going to have you go right about there.
Okay.
And turn your head this way just
Okay.
a little bit. Now look at my finger. Now look at my nose. Finger, nose. Finger, nose. Now over here, my finger, back of my nose. Finger, back of my nose. Finger, back of my nose. You are really, really good at blinking every time you look at my nose on this side. And it obscures just the thing I'm trying to see.
I'm sorry.
Do you think you could look at my finger and then look at my nose and try not to blink?
I will
It's
try my
actually-
best.
It's actually pretty hard to do.
Okay.
So look at my finger, now my nose. Good. Finger, nose. Finger, nose. Finger, nose. Finger, nose. Well,
Did I do it again?
No, you're doing the blink thing perfect. Go ahead and blink a few times,
Okay.
because you're. But your eye it was doing it a little bit better a few minutes ago, and that's that's this disease for you. It'll come and go pretty quickly. But essentially, what you were doing before is when you were looking this way and you would look back to my nose, you would overshoot and then make a couple corrections. You're not doing it quite as much. I can see it a little bit episodically. Let's try one more time. Look at my finger and my nose. Finger, nose. Finger, nose. So you do it a little bit more when you go from this direction to my nose than you do from this direction. I can see it. I'm not sure how well it'll show on the camera. Look at my nose. Yeah. Finger, nose. Finger, nose. Yeah. So there's a little bit of overshoot and a brief correction to get back on target. Let me have you look up, and way down. Are you seeing double in any of these places? No?
No, sir.
And then this way, double anywhere there?
No, sir.
Okay. Now I want you to look at my finger and look at my nose. Finger, nose. Finger, nose. Yeah, she has. Also has it vertically as well, too. Yeah. I'm going to hold your eyelids up now. I want you to look down at my finger.
Okay.
And look down at my finger, and then back at my nose. Finger, nose, finger, nose. Do it a little slower. Nose. Yeah. So, and again, it's actually a little bit more in the left eye than the right eye, even in that asymmetry. Again, this is peculiar to demyelinating disease in the brainstem. Usually it's going to be a little more pure and isolated than this. But now that's a problem that can also go along with some coordination, maybe even some balance issues. But sometimes it's when it's subtle like this, it's pretty isolated. Probably when you're more tired and fatigued, it's a little more noticeable. But in general, that's from some of the damage in your brainstem. So, thank you.
Thank you.